today we saw different approaches to deal with this epidemic of periimplantitis. We expect, or we think that in Spain we have 1 million people with periimplantitis, according to our last prevalence study from SEPA. So it's a major concern because we don't have a good protocol or guidelines as we have for periodontitis.
That's true.
How do you think we can manage in the future the periimplantitis in the near future?
I mean, I think we have to accept that in the near future, we just have to face what's coming, right? I mean, whatever we implement, any protocol, it will take longer time to have an effect. So I think for now, we have to deal with the situation as it is. And I saw your estimations. I think we will be very busy. I mean, no way around it. So I think that the protocol that the EFP, for instance, is suggesting, preventing periimplantitis by treating mucositis, and that I think is the what's going to help us down the road, and everything that comes with it. So let's say preparing the patient, so patient selection, proper treatment, proper pros, and having a maintenance program. So I think there's no magic tool. It's the basic. I mean, it's the homework that we should do. So I think we're going to have to face what's coming and then really just go back and take care of the basics. No way around it.
The normal situation is in 80% of the population, without treatment, you develop periodontal disease in a slow progression pattern. Then you have 10% of people, they are quite protective, and 10% they are high responder. But the problem that I see is you place implants and you put the patients on maintenance, and despite the fact that you do a proper maintenance, the patient is doing well, there is still like 5–10% of the patients that they will develop periimplantitis. So we know that with periodontitis we can have this kind of recalcitrant periodontitis, but I have this feeling that even we can do everything as we have in our hands, we cannot 100%.
No, I mean, of course, we all have patients that immediately come to mind that, we don't know, everything seems to be under control and still they go downhill. But, I don't think I would necessarily make a big difference to perio, because I think we can all also pick up immediately a perio case, where the exact same thing applies. I mean, you have the control over virtually all aspects, but still the patient goes downhill, right? So to me, there's a small group of highly susceptible individuals, periimplantitis, where we fail. And I think that it's probably even the same group, right? It's the same patients. So I wouldn't distinguish very much. Having said that, I mean, of course, we could also argue that the peri-implant tissues may be even less resistant as perio tissues would be. So I think there are it's plausible if you want.
In fact, we were working in our group trying to develop a soft tissue interface that tries to simulate what is on teeth with these supracrustal attachment fibers. We couldn't find a difference doing this kind of slightly rough, just etching surface, because the collagen fibers organize a bit more perpendicular. But you think in the near future we can develop the implant for the transepithelial part that I think is the critical.
Now, I'm not so sure if we can ever mimic, the supracrustal attachment that we have around teeth. So, we have to see. I'm somewhat doubtful. But what I do like is that the focus, research-wise, clinical-wise, is on the supracrustal part. I mean, traditionally we have focused on the osseous part, osseointegration and so on and so on. And now I think we seem to understand that whatever will determine success or failure is rarely the osseointegration. It's the compartment above, which is the soft tissue integration. So I think, you are talking about microstructures, nanostructures. That for sure is a future research area, but I think also we now already today can do a better job by having implant geometry, macro geometry that respects the required dimensions. And we design the prosthesis, the super constructions, in a way that we don't violate the dimensions again that we need. So I think that we can do today already, preventing mucositis, preventing periimplantitis.
Yeah, on the other hand, some companies are studying, silver coatings as a protective against bacteria, but it's a temporary solution, right? Because this is not last forever.
No. And I
protected,
think we also heard Leo Shapira talk about a coating that will also prevent the progression of bone loss. But I think historically these attempts have failed, right? I mean, these coatings, they don't, as you say, they're temporarily, they're not maintained, they degrade. So whatever will happen years down the road, most likely it will not be affected. So I don't know if this is really the right way to go. I think it's the soft tissue integration, and it is dimensions and materials that we have to work with.
You have any question, please?
We have to think about tissue stability, what we have to do first in our implant therapy. So if we have the definition what tissue thickness we have in bone and soft tissue, we know a little bit about stability, but still we won't get attachment. But I think we already have a surface which give us a mechanical stability, which is the microchannel surface. And I have about 7 years experience on this. And we use it not on the implant neck, on the abutment. So this surface give us the opportunity to establish the biological width much higher than we have on the implant now. And we did a study, Frank Schwartz and I, in 2012, and looked to machined abutments and 1 millimeter of microchannel and 3 millimeters of microchannel. We saw immediately the epithelial downgrowth in healing was much higher with 3 millimeters of this. So I think this is the first step to move on and look at it, Yeah. And we just finished a study, looked to the health around such abutments compared to smooth surfaces, machine surfaces, and with the cytokines were different. So this is, I think, the first step we have to look at in future, because we need, first of all, a test which shows us what is really mucositis, and the second is how we can deal with it. Because we have no really good definition yet, about mucositis and periimplantitis. It's not really, let's say, in the world, the same definition.
Now that's true, right? We have certainly different case definitions.
And we see in clinical studies, when we do our probing, we never know, is it maybe inflammation, or maybe we hurt our attachment or our adhesion. So this is always a big issue from my opinion.
We were doing also, as I said, some research similar to that, but not with microchannels, but just with, like Francois, with this Straumann tissue level with some, what they call ESTA surface, enhanced soft tissue adhesion, but we couldn't find a great difference. What we found, a bit of much better epithelial attachment, was with the zirconia implant, where we have shorter circular epithelium and we have better adaptation. So it would be nice maybe to develop an experimental periimplantitis model with these microchannels. I'm very fan of that, because I saw all the papers from the 80s from the Canadian group. They developed on the skin of the rats to avoid the epithelial downgrowth with these microchannels in titanium plates. That was very interesting. So that's why, to me, the critical part is the absence of attachment of the connective tissue part. That's why we have on implants like a almost open environment close to the bone, not like as in the on teeth. So I like that way, and also with this kind of switching platform, etc. But we need to try to see experimental model at least.
You know, we published last year two-center study, Frank Schwartz and mine, with the experimental mucositis, and we compared again this machine abutment with the laser lock abutment, and what we saw was after the healing phase, before the patients stopped doing hygiene, when we did the probing, we had on one side on the machined abutments 48% of bleeding, and on the laser lock 13% of bleeding. So it could not be mucositis, for my opinion, because after a healing phase where the patients make hygiene in a proper way, how it could be so high compared to the microchannel surface. So my conclusion was it's the stability of the tissue, though it's less bleeding. It just shows me stability, not any inflammation.
No, I mean, I have nothing to add. I would agree, of course, that the differences that you highlight are quite pronounced, right? So there might be something more to the story than just a simple mucositis.
I like always the paper by Benstrom, the 2004, I think, was study with the Astra thioblast partial dentures versus in the same patient with the machine, same implant, and they prove that well, if you do 6 months close second stage surgery, after 3-5 years you have even much better result with the machine. I asked Cristiano Tomasi, I think 2 years ago, why don't you bring now so many years after the results? Because we want to see in longer term. And was the Donati paper where clearly showed that in perio patients, probably they were treated, a machine implant at the bone level could be also sound option. So also I was considering this kind of hybrid implants at least as a preventive thing.
No, I think the data that you bring up now is one of the few studies that really addresses the question that we are now talking about in a clinical setting, long term. So it's clinically meaningful, and the differences were quite pronounced, as you say, right? I mean, now in terms of bone level, bone loss over 20 years, it's factor 2 in favor of the machine surface, right? So it's going against the claims that are usually made that you preserve marginal bone levels. So I think, you know, this is a little bit the traditional Scandinavian approach. We're not so fond of these. You know, I don't think we'll find the solution in a modification of a surface, be it the implant or the abutment. The secret to the story is probably that patients were well prepared, perio was treated, the treatment was done in a controlled way. You know, that's what made the story in the end. So actually the story was the other way around. The modified surface was worse off. So it puts to the question, shouldn't we go back where we started maybe and keep it simple in terms of surfaces, you know? And if you do get a problem, I mean periimplantitis, we all know, and that is so strong, that the less complex surface, smooth surfaces, so much easier to handle if the problem arises in the first place, right? So you could argue that, you know, what's left that is favoring the modified surfaces, and probably it's difficult to argue. I mean, I'm sure have you seen differences in the non-surgical protocol for the modification of the surfaces?
Yeah, I mean, I don't have many cases with machine surface,
No.
but I saw some machine cases where they have like a pattern of not the accelerating pattern of progressive bone loss, but more like a self-arrested sometimes pattern, but not many. The problem that I saw more was with some surface like osteospeed. So I think, for example, thioblast is it's a nice surface, but with osteospeed, I have this speed. The case that I showed today was a case that was treated surgical at that time, 10 years ago, and the patient was still losing bone and was on osteospeed. I was in just 3 years the bone loss. So yeah, I have this experience because I use osteospeed a lot in the past. Fantastic implant, but once, if you get a bit of bone loss, it's going to be...
So among the modifications, they're also different, right? And I think this is what we also saw in Olivier Caquac's study is that we say modified, but you know it's one group, but it's probably a diverse group as well. So we may have to be a little bit careful and more specific about what modification we are speaking of. So I mean, that's quite obvious, I think, and all the centers working on this. I mean, your center, if you look at Mario Rocuzzo and Frank Schwarz, our center, I think they would all agree on this.
So thank you very much.